In medical news tonight, we take a look at the connection between certain breast cancer treatments causing an increased risk of some heart disease for some patients. The American Heart Association recently released a statement on the connection, and Carolee McGrath sat down with non-invasive cardiologist Dr. Heba Wassif from Baystate Medical Center to learn more.
It's a new emerging paradigm in my mind, for three reasons. There are common risk factors between breast cancer and cardiovascular disease, like a sedentary lifestyle, certain diets, excessive meats, for example, smoking that has some association also with breast cancer. So both diseases can exist in the same person. So a person can be suffering from breast cancer as well as cardiovascular disease. The second reason is there are many treatment options now for breast cancer that have some cardiovascular toxicity that I believe we'll be discussing later on. So it is important to know what an individual's underlying cardiovascular risk is. And the third, obviously, that if you have underlying cardiovascular disease, that may determine or direct some of your treatment options for breast cancer.
So what types of treatments are we talking about that would be the most aggressive and cause problems with the heart?
So one of the most aggressive treatments is a group of drugs called anthracyclines. And there are several of them in the group. Some of them cause more cardiotoxicity than others.
Explain that for the layperson.
For the layperson, cardiotoxicity, because as these drugs are toxic and kill the breast cancer cells, they also kill the myocardial cells, the cells of the heart. They have the same impact, so they interact with the DNA in a similar fashion that they would do with the tumor cells. But here now we're talking about a living heart cell. Right. And therefore it can potentially cause weakness of the heart muscle. These drugs were used from the early 70s. It wasn't until almost 10 years later that we've discovered some of these toxicities, so to say. And we've also discovered that it's somewhat dose dependent. And I will qualify that statement, that the higher the dose, the more risk for the heart muscle. However, there are some individuals that are more susceptible, even at very low doses. They can potentially have problems with their heart muscle.
And what kinds of conditions are those individuals in? They already have underlying factors for heart disease?
Exactly. So if they have underlying cardiovascular disease, or if their heart muscle is like borderline weak, so what we define a strong heart muscle in the world of medicine is a heart muscle that pumps about 60% of the blood. If your heart muscle is borderline, 50 to 55%, then we're starting at a weaker heart muscle that can potentially be at risk. And some of it is all can. There are no certainties. It's a world of uncertainties. But we can only try to find what are the possible associations that would increase the risk, identify them, and then modify what we do to minimize that risk. So if an individual is over 60 years old, they have 2 or more cardiovascular risk factors, they have a weak heart muscle, as I mentioned, like a borderline heart muscle, then we have to maybe use less aggressive therapies or do continuous monitoring at the beginning of the treatment, as the treatment progresses, and even after the treatment is terminated, because some of these effects could be very late after the treatment has ended.
But I think, when women hear breast cancer, it's an automatic, as it should be. You're frightened, you're so worried about, your future, your children, your husband, and what the medical outcome will be. So I'm sure people are saying, give me the strongest, treatment possible because I want to get rid of this, right? Because you have to treat it aggressively.
Absolutely. And that's not having said that because of the concern of cardiovascular risk or cardiotoxicity, that doesn't mean that we should hold treatment for breast cancer. You have to treat the cancer. If it's aggressive, you're more likely then to die from breast cancer than dying from cardiovascular disease. Some of these possibilities may be long-term. Mm-hmm. And because we have long-term survivors, we are seeing more women that are surviving breast cancer, which is an amazing endeavor that has been achieved over the last 25 years, that the mortality from breast cancer has been reduced significantly. We're seeing women that are now dying as older women from cardiovascular disease rather than who had breast cancer.
Okay.
Not from the recurrence of the breast cancer, but rather from cardiovascular disease. So it's important to identify who's at risk first, and it is an evolving field where there's a lot of work that's currently been done, and it's also been identified as a unique subspecialty of cardiology, which is almost new in existence over the last few years.
And give us some of the numbers as far as the mortality rates for heart disease versus breast cancer.
So to put things into perspective, there are more women living with cardiovascular disease in the US than there are women with breast cancer. There are almost 48 million women with cardiovascular disease, and 1 out of 3 women will die from cardiovascular disease, and I mean cardiovascular disease including stroke as well. And 1 out of 31 women will die from breast cancer. So women are more likely to die from heart disease than they are to die from breast cancer. But this is, again, an epidemiologic. We're identifying all breast cancers with all its stages and all its forms, as well as cardiovascular disease. It doesn't speak for the particular individual.
Right. How do you work with the oncologist when you have a patient who has heart disease who is also being treated for breast cancer? Tell me how that relationship has to work to best benefit the patient.
As I said, this is an emerging paradigm, and it's an evolving collaboration now between cardiologists and oncologists. So the oncologist is the primary treating physician. They identify what is the most appropriate therapy for the patient, but they work hand in hand with the cardiologist to first monitor the patients from a cardiovascular standpoint. For example, if the heart muscle is relatively weak to start with, then maybe initiating certain therapies may be advisable. If heart weakness occurs during the therapy, adjustment of the treatment options is warranted, and this continuous monitoring by cardiac echocardiography, which is the ultrasound that we do for the heart muscle, is very important, where a cardiologist continuously monitors along with the oncologist. So it's a collaboration at the beginning of the therapy, in the middle of the therapy, and even after the therapy is terminated, because some of them may be long-term effects.
So I know you're a medical doctor, but I have to imagine that you see the emotional side of your patients. So here you have breast cancer, and now you are at high risk, for a heart, some sort of a heart failure or high risk of heart disease. I mean, that's like 2 major things that people would have to deal with. How do you help patients understand the process? It's
obviously that you can't take the emotion out of either conditions. There's a lot of emotions associated with them, and people are people. We're human beings. But at the end of the day, this is life-threatening on both ends. It's all about assessing risk. What's the most risk now? And if the breast cancer is the most risk, which usually is immediately, then you manage the breast cancer and you monitor. And you may, as I said, maybe use less aggressive therapies. And there are less aggressive therapies, but it has to be with the agreement of the oncologist that is an appropriate therapy for that particular patient.